The wound has already healed when the disease finally introduces itself. Maybe a dog bit your hand 2 months ago. Maybe a bat left a mark so small you barely noticed it. The bleeding stopped. The skin closed. Life continued long enough for the danger to become embarrassing to mention. Then the old bite begins to tingle. You develop a fever. Sleep becomes difficult. Anxiety arrives without a clear object. A glass of water is placed in front of you, and the muscles in your throat contract so violently that your body recoils from the thing it needs most. You remain thirsty. You try again. The same spasm comes back. By the time this happens, the treatment window is usually gone. Plague has killed cities. Smallpox killed hundreds of millions and left survivors scarred or blind. Cholera can drain enough water from a body to kill within hours. Each has a legitimate claim to being one of history's most horrifying diseases. But if terrifying means the disease that combines anticipation, mental disintegration, physical torment, and near certainty of death after symptoms begin, one candidate stands apart: rabies. It does not win by body count. It wins by making the victim understand, piece by piece, that something entered the body weeks or months ago and has only now reached the place from which it cannot be removed. Let's go through it properly. There is no scientific unit called terror. You cannot place smallpox, plague, cholera, rabies, tuberculosis, influenza, and Ebola on a laboratory scale and receive one clean answer. Fear depends on what a disease does, how quickly it does it, how visibly it spreads, whether the victim remains conscious, whether anyone understands the cause, and whether treatment exists. Smallpox may be history's strongest candidate for the most destructive recognizable disease. Ordinary smallpox produced high fever and deep lesions that spread across the face and limbs. In unvaccinated populations, its overall case fatality rate was about 30%, while rare flat and hemorrhagic forms were usually or overwhelmingly fatal. Survivors could carry extensive facial scarring, and some lost vision through corneal damage. The World Health Organization estimates that smallpox killed roughly 300 million people during the 20th century alone before vaccination eliminated natural transmission. Plague created a different kind of fear. Bubonic plague produced painfully swollen lymph nodes, while pneumonic plague attacked the lungs and could spread through respiratory droplets. Without effective antibiotics, bubonic plague killed a large share of patients, and untreated pneumonic plague approached total fatality. A person could watch the disease move through households and streets while having no reliable way to stop it. Cholera made the human body appear to empty itself. Severe watery diarrhea and vomiting can remove fluid so rapidly that shock, kidney failure, collapse, and death follow within hours without treatment. The maddening part is that the central treatment is not a rare antidote. It is replacing water and salts quickly enough. A disease that once looked like an unstoppable curse can often be defeated by organized rehydration. Rabies is different from all three. It generally does not spread efficiently from person to person. It does not sweep through cities in the same way plague, smallpox, or cholera can. Its annual global death toll is measured in tens of thousands rather than the millions killed during the largest historical pandemics. Most human cases still follow bites from infected dogs, especially in parts of Africa and Asia. Rabies is terrifying on the scale of one person. A bite happens, then nothing. The virus may remain hidden long enough for the victim to stop thinking about it. The usual incubation is measured in weeks or months, often around 2 or 3 months, but it can range from about a week to a year. The exact timing varies with the exposure and the route the virus takes towards the nervous system. This delay creates the first horror. You can feel completely healthy while the disease is advancing. The virus usually enters through infected saliva deposited by a bite or scratch. It does not need to flood the bloodstream and announce itself to the immune system like an invading army crossing open ground. It gains access to peripheral nerves near the wound and travels inward through the nervous system toward the spinal cord and brain. Later, after multiplying within the central nervous system, it spreads outward again to tissues including the salivary glands, helping continue transmission through another bite. The journey is microscopic. The consequence is not. Imagine being bitten in a world before vaccines, germ theory, or laboratory testing. The animal behaves strangely, but perhaps it escapes. The wound is cauterized, cut, covered with herbs, prayed over, or treated with whatever local experience recommends. Then the skin closes. You wait. Every headache becomes suspicious. Every restless night acquires meaning. A person might remain healthy and eventually relax, or the original wound might begin burning, itching, or tingling weeks later. A classic early clue that the nervous system near the exposure is involved. Fever, weakness, headache, and general discomfort can follow, all common symptoms shared with countless ordinary illnesses. The disease hides inside normality one final time. Then the brain changes. Rabies causes progressive inflammation and dysfunction of the brain and spinal cord. Clinically, it usually appears in one of two broad forms: furious rabies, marked by hyperactivity, agitation, hallucinations, hydrophobia, and sometimes aerophobia; or paralytic rabies, in which weakness gradually becomes paralysis, followed by coma and death. The paralytic form accounts for roughly one-fifth of human cases and is easier to misdiagnose because it lacks the famous violent presentation. Furious rabies is the version that gave the disease its ancient reputation. The victim may become anxious, sleepless, confused, agitated, or delirious. Hallucinations and seizures can occur. Saliva accumulates because swallowing becomes difficult. Periods of extreme arousal may alternate with moments in which the person is conscious enough to understand that something catastrophic is happening. Then water becomes impossible. Hydrophobia is often described as a fear of water, but that phrase makes it sound like a belief that could be discussed calmly. The patient may be intensely thirsty and still recoil from drinking because attempts to swallow trigger painful, involuntary spasms in the throat and breathing muscles. In advanced cases, merely offering water can provoke the reaction because the nervous system anticipates the act of swallowing. The water is safe. The body treats it like an attack. This is one of the most disturbing symptoms in medicine because it turns survival instinct against itself. The victim sees relief, wants relief, and cannot make the body accept it. Thirst remains. Saliva collects. The muscles involved in swallowing and breathing become part of the disease. Air can become threatening too. Aerophobia does not usually mean a philosophical fear of the atmosphere. A light draft or air blown toward the face can trigger sudden spasms and an intense startle response. Water and moving air, two of the most ordinary sensations in life, become triggers inside a nervous system that can no longer process them normally. A person in this state may appear possessed. For most of history, that interpretation would have been understandable. The victim may hallucinate, struggle, drool, recoil from water, react violently to small stimuli, and alternate between recognizable personality and neurological chaos. The illness attacks the organ through which the person normally proves they are themselves. This is why rabies accumulated supernatural explanations so easily. A fever can look like illness. Rabies can look like the person has been replaced. In animals, the pattern can be equally disturbing. Rabid mammals may become unusually aggressive, disoriented, fearless, weak, or paralyzed. Not every infected animal foams at the mouth or attacks everything nearby. Some become quiet and impaired, but behavioral change, biting and virus-rich saliva, create a transmission system in which disease alters the host in ways that can bring the virus into another nervous system. Researchers caution against saying a virus consciously controls an animal. Evolution needs no intention. Variants that spread effectively remain in circulation. The virus has no plan. Its effects still look planned. That distinction matters because popular descriptions often turn rabies into a perfect zombie virus. It is not. Human-to-human transmission is extraordinarily rare, and people with rabies do not form contagious armies. The disease survives mainly through animal reservoirs and bite transmission, especially through dogs in the overwhelming majority of human cases worldwide. Rabies is not terrifying because it could end civilization. It is terrifying because civilization can continue normally around one person whose outcome has become almost fixed. Paralytic rabies removes the theatrical symptoms without offering mercy. Weakness may begin near the bite and spread upward. Limbs lose function. The condition can resemble other neurological disorders. Because hydrophobia and agitation may be absent, clinicians can miss the diagnosis. Paralysis progresses, coma develops, and breathing or cardiac function eventually fails. Furious rabies looks like madness. Paralytic rabies looks like disappearance. Both converge on the same ending. Once clear clinical symptoms appear, rabies is virtually always fatal. WHO states that the disease is fatal once the central nervous system is infected, and clinical illness begins. CDC describes it as nearly always fatal after signs appear, with severe disease progressing rapidly toward coma and death. Rare survivors have been reported, sometimes after intensive experimental care or prior vaccination, but they remain exceptions so unusual that they do not produce a dependable treatment strategy. This creates the second horror. Rabies is one of the rare diseases in which medicine can be extraordinarily effective before the patient feels sick and nearly powerless after the patient finally knows they are sick. Post-exposure prophylaxis works by stopping the virus before it establishes fatal infection in the central nervous system. Modern care includes immediate wound cleaning, rabies vaccine, and, when indicated, rabies immune globulin placed around the exposure. CDC describes appropriate post-exposure care as nearly 100% effective when provided before symptoms. The bite is the emergency. The symptoms are the aftermath. By the way, if you want to go even deeper into the secret lives of ancient humans, I just launched a full course called The Secret Lives of Ancient Humans. 10 modules, 3+ hours of content covering everything we never talk about on YouTube. What they feared, how they communicated, what hunted them, and much more. Plus an exclusive PDF guide included. Link in the description. See you inside. That reverses the logic people use for most illnesses. Normally, you feel unwell and then seek treatment. With rabies, waiting for proof can destroy the possibility of rescue. You may need several injections and urgent medical evaluation while feeling perfectly normal, because feeling normal is the only stage during which prevention can still work. Rabies therefore punishes hesitation. The animal looked healthy, the scratch was tiny, the bite happened while traveling, the child did not tell anyone, the wound was washed and forgotten, the family could not reach a clinic, the vaccine was too expensive, unavailable, or stored too far away. The disease is preventable in principle and still kills tens of thousands each year because prevention has to arrive in the correct place before an invisible deadline. WHO estimates about 59,000 deaths annually, concentrated mainly in Africa and Asia, with children carrying a large share of the burden. The fear also changed how societies treated animals. A normal dog was companion, guard, hunting partner, and scavenger. A dog behaving strangely could become a moving uncertainty inside the same streets where children played. Communities killed suspected animals, restricted dogs, or developed rituals intended to protect against bites. Some responses reduced danger. Others punished healthy animals because the disease could not be confirmed in time. Rabies therefore damaged trust between species as well as bodies. The animal closest to human domestic life was also the animal most capable of carrying the disease to the doorstep. A person did not need to enter a remote forest or survive an exotic expedition. The threat could know the way home. Rabies is ancient enough that early civilizations recognized the pattern long before anyone understood viruses. Mesopotamian writings from roughly 4,000 years ago connected dangerous dog behavior, biting, and later human death strongly enough for legal responsibility to enter written rules. Ancient Greek and Roman writers described madness in dogs, bite transmission, and hydrophobia. The explanations were incomplete, but the observable sequence was too distinctive to miss. A dog changes. The dog bites. The person changes. The person dies. That is epidemiology before microscopes. The treatments reveal how frightened people were. Wounds were burned, cut, excised, or treated with preparations drawn from plants, animals, minerals, and ritual practice. Some methods accidentally contained useful logic. Immediate washing can reduce exposure. Thorough wound washing remains part of modern prevention, although mutilating or burning the wound is not a substitute for vaccine and medical care. Other treatments were desperate theater. When a disease kills nearly everyone after symptoms appear, every survivor of an uncertain bite can be credited to whatever remedy happened nearby. The animal may not have been rabid. The bite may not have transmitted the virus. The patient lives, and the herb, prayer, cautery iron, or fragment of animal anatomy receives a promotion. Medicine before controlled evidence was especially vulnerable to diseases that did not infect every exposed person. The unsuccessful patients could not leave reviews. By the 19th century, rabies remained uncommon compared with diseases such as tuberculosis or smallpox, yet it produced enormous public fear. A suspected mad dog could generate panic because the bite began a period of waiting with no reliable cure. The victim might remain healthy for weeks, not knowing whether the animal had delivered a death sentence. Then Louis Pasteur and his collaborators changed the timing. Pasteur did not cure a brain already overtaken by symptomatic rabies. He developed a way to train the immune system during the incubation period, exploiting the delay between bite and neurological disease. In July 1885, 9-year-old Joseph Meister arrived after being bitten 14 times by a dog believed to be rabid. Pasteur's team administered a course of experimental inoculations derived from treated rabies-infected nervous tissue. Meister survived. The case was scientifically and ethically complicated. The method had been tested in animals, not established as safe treatment in humans. Pasteur was not a physician, and failure could have killed the boy or damaged the credibility of vaccination itself. Doing nothing carried its own experiment. The expected result was death. Meister's survival transformed rabies from an ancient certainty into a race that medicine could win. People traveled to Paris from other countries seeking treatment. The demand helped produce the institution that became the Institut Pasteur, built partly around preventing rabies and studying infectious disease. This was more than a vaccine story. It revealed something strange about rabies biology. The disease gave medicine time. The virus could already be inside the body, yet the immune system could still be prepared quickly enough to stop it before the brain became involved. Vaccines are normally imagined as protection received before exposure. Rabies made vaccination after exposure one of the most dramatic rescue procedures in medical history. The delay that created months of terror became the delay that allowed survival. Modern vaccines are far safer and more standardized than Pasteur's early preparations. Post-exposure care now begins with something almost offensively simple. Wash the wound thoroughly with soap and large amounts of water, then seek urgent professional assessment for vaccine and immune globulin when indicated. WHO advises flushing a potential exposure for about 15 minutes. Soap, water, medicine, speed. 4 ordinary things standing between a bite and one of medicine's worst deaths. That simplicity can create false confidence. People may assume rabies is now solved everywhere because the technology exists. But a vaccine stored in another province does not protect the child who cannot reach it. A family may not recognize the risk. Health facilities may lack immune globulin. Dogs may remain unvaccinated. Poverty turns a preventable disease back into a fatal one. The virus is ancient. The inequality delivering it is modern. There is also no comfortable test that lets an exposed person sit at home until a laboratory announces whether the bite took. Current diagnostic tools are not suitable for reliably detecting infection before clinical disease appears, so doctors make decisions from the animal, the type of contact, local rabies patterns, vaccination history, and whether the animal can be safely tested or observed. Waiting for symptoms to settle the uncertainty is the one method guaranteed to provide the answer too late. The position and severity of an exposure can influence risk and incubation, but they do not create a reliable countdown. Rabies. Timing remains highly variable. That is why every credible exposure is treated as urgent rather than placed on a calendar according to how calm the patient feels. Most human victims do not pass rabies onward. Humans are usually an evolutionary dead end because ordinary contact does not efficiently move infected saliva into another person's tissue. The main cycle continues among mammals, with dogs serving as the source of up to 99% of human cases worldwide. In different regions, bats, foxes, raccoons, skunks, jackals, mongooses, and other mammals can maintain related transmission cycles. This is why the most effective rabies intervention often happens before any human is bitten. Vaccinate dogs. A vaccinated dog cannot efficiently carry the virus from the animal reservoir into a household. Large-scale dog vaccination, public education, bite prevention, and accessible post-exposure care break the chain at several points. WHO describes dog vaccination as the most cost-effective strategy for preventing human rabies. That may sound less dramatic than a scientist rescuing a dying patient. It is more powerful. The best rabies treatment is the case that never enters a hospital, the child who is never bitten, and the dog that never becomes infected. Public health wins by making the terrifying story too uneventful to tell. So is rabies truly history's most terrifying disease? Not by total deaths. Smallpox is far ahead if the measure is cumulative killing and disfigurement. Plague is stronger if terror means watching a fast epidemic consume an entire city. Cholera may be worse if terror means seeing a living person collapse from fluid loss during a single day. Influenza pandemics killed with a scale rabies has never approached. Rabies wins only under a particular definition. The most terrifying disease is not necessarily the one most likely to kill you, it is the one that makes the path to death feel designed around fear. A forgotten bite, a silent incubation, a tingling scar. The gradual loss of sleep and certainty. The inability to swallow water while remaining thirsty. The possibility of lucidity between spasms. The knowledge that treatment would have worked earlier. Then coma. Then death. No other disease combines those elements in quite the same sequence. There is one more reason rabies feels different. Many lethal infections overpower the body. Rabies appears to turn the body's own communication system against the person inside it. The nerves that carry touch, movement, swallowing, breathing, attention, and fear become the road and then the battlefield. The disease does not simply damage an organ you can imagine as separate. It invades the machinery through which you experience being alive. And yet the final lesson is not hopeless. Humanity did something extraordinary with this disease. People observed the pattern for thousands of years. They learned that bites mattered. They tried to remove the danger from wounds. They identified the connection to animals. Then laboratory science found a way to use the incubation period against the virus. Today, a person can be bitten by a rabid animal, receive the correct care promptly, and continue living without ever experiencing the disease. That is not a small achievement. It is the conversion of a death sentence into an urgent appointment. But the appointment has to happen. Rabies remains terrifying because it divides time into two worlds. Before symptoms, medicine can save you. After symptoms, it usually cannot. The wound may look healed. The decision is not. History's most terrifying disease does not begin when the victim becomes afraid of water. It begins when everyone decides the bite was probably nothing.